And so a bronchodilator can be used acutely for these people to help them clear that nasty stuff out of their alveoli. The next drug class I want to touch base on is antibiotics. And obviously, antibiotics can be used in multiple infections, not just in pneumonia, but in this context, recognize that we don't always know what the organism is down inside that person's chest until we can do that sputum culture and sensitivity, until we can do a gram stain of that sputum. All right, so initially, the physician will order what we call a broad spectrum antibiotic, meaning that particular antibiotic has been shown to be effective over a wide variety of bacteria that are occurring in our geographic area. As you begin to practice and you have more than one patient a week, like you do right now in clinical, you will begin to see the pattern of the way physicians prescribe. Typically, when the pneumonia begins its sweep during the winter months across our area, multiple physicians will order the same antibiotics, or perhaps 1 out of 3 in the same drug class of antibiotics consistently. And it's like, did these guys talk about this? Or did they just have a revelation and they all had the same dream? What is that about? Because they do communicate, but then they recognize that particular drug type, that particular type of antibiotic is effective, and so all of them will use it until they see different. Okay? Next winter, it might be a different kind of antibiotic. This may be easy, depending on what we're dealing with. But recognize that antibiotics do not treat viral infections. Only antiviral meds that we'll talk about, not that we will talk about, that we already talked about in the HIV lecture, treats a viral infection. And those of you who have had influenza this winter, perhaps was placed on an antiviral as well, and while you recovered. There are different types, but they basically all interfere with that organism replicating. 1's a problem, 2's a bigger problem, 3's a bigger problem, etc. And bacteria can replicate sometimes within just a few minutes. It can double itself. We have IV antibiotics, IM antibiotics, and oral antibiotics. The oral forms, of course, being liquid or tablet. I've given you 2 of the common IV forms that we use. I say IV, ceftriaxone can be given IM as well. Typically, when we give it IM, we mix it differently than when we use it for IV. So some nursing implications for this drug class is, if you remember, I think I mentioned to you all that the 3 drug classes that are most commonly known to cause allergic reactions to people are what? Anybody at any of the 3 campuses? What were those 3 drug classes that I mentioned? Remember? Somebody said one of them. Antibiotics is one. Somebody said another one. NSAIDs. Okay, what was the 3rd one? Opioids or narcotics. Okay, those are the 3 most common ones. And when I say NSAIDs, I want you to lump aspirin in there as well. Some people think of aspirin as an NSAID. Technically, it's not. It's a little bit different, although it is anti-inflammatory as well. But for our purposes, lump it together. So with that being said, first dose antibiotic, first dose any med, we should always assess for those person's allergies. Antibiotics, unfortunately, because they kill things, can also kill tissue. And so there are multiple ones that damage our kidneys if we already have kidney injury to begin with, or are just vulnerable to that. If at all possible, we want to collect a sputum sample before we give that first dose. However, core measures, and I don't remember if we've talked about core measures yet. I think that's actually in my pre-op, post-op lecture. But core measures are a group of consistent standards of care that the government says that every person should receive based on a specific diagnosis. So there is a set of what we call pneumonia core measures. There's also core measures for numerous other things. But for this context, we're talking about pneumonia, so that's the only one I'm going to focus on. One of those core measures is that the patient received their first dose of antibiotic within an hour of being diagnosed with pneumonia. Okay, so if you can't get a sputum within that first hour, we still go ahead and administer the antibiotic. And then make sure that as part of our patient teaching, the client understands that even if they feel good and maybe even have gone home, they need to finish the entire script. We don't want a drug-resistant form of bacteria to develop that would spread across the community. Next drug class is expectorants. Expectorants means simply that when you administer it, you expect something to come out, right? That's simply what that implies. Expectorants reduce the stickiness, if you will, the adhesiveness, as well as the surface tension of those secretions that are accumulating. As a result, the client typically can cough them up more easily. There are both liquid and tablet, but all expectorants, to the best of my knowledge, there is an only oral form. I don't know if an inhaled one I'm aware of. And the most common one we see in our area is guaifenesin. You see it in over-the-counter medicines, you see it as well as in prescription form. You might have heard of it as Humabid or Mucinex, or Robitussin. The two most common side effects are nausea and drowsiness. And in order to be effective, we want to make sure the client is drinking plenty of fluids. So remember we said 1.5 to 2 liters is for a healthy person. These people, we'd like to bump it up to 2 to 3 liters per day, as long as they don't have a cardiac or renal problem. And then recognize that it does have drug interactions, particularly with anticoagulants. And so we have to use it cautiously so the person doesn't become at risk for hemorrhage while we're trying to help them cough things up. Heaven forbid they break a rib from coughing and they're on an expectorant and heparin and then they bleed internally. Okay? Next drug class, antitussives. Antitussives are those things that suppress our cough. So they work directly on that part of our brain that triggers our cough reflex, and that's in that medulla, in that respiratory center of our brain. However, they're really not desirable during those initial stages with pneumonia unless that person's cough, that non-productive cough, is keeping that patient from getting some sleep. So we might administer it during the late evening or early, that bedtime area, 9 or 10 o'clock, to give them 3 or 4 hours of decent sleep, rather than them staying awake day after day, coughing and coughing when it's still too thick to bring it up. Okay, so we use it cautiously, but recognize even if we use it during the daytime, actually I think this is under nursing implications. Yeah, it is. I'll say that. All right? So antitussives come both in liquid, capsule, or even a lozenge that the person just sucks on. And these are two commonly used ones, but recognize that virtually all narcotics have an antitussive effect. So you might have already had a patient in clinical that you gave hydrocodone or Loratab or Norco for, and you thought, I don't see anything in this patient's chart that deals with pain. Well, maybe they're just hurting because they're coughing so much. Well, chances are the physician was using it as an antitussive rather than an analgesic. Side effects: dizziness, drowsiness, nausea, vomiting, constipation. Okay. Some nursing implications, I listed a couple. Make sure that because of that dizziness and drowsiness effect, that you help them when they need to get up to the bathroom, when they want to ambulate, just to make sure that they're not tipsy from that antitussive. And then make sure that if we are giving it, that we instruct them to cough intentionally during those waking hours to make sure they cough and clear, all right? It's not unusual for a client to receive both an expectorant and antitussive as well. We're going to try to loosen those secretions with the expectorant, make it easier to cough up, but we're not going to necessarily rely on the reflex. We're going to make it on purpose that they cough them up. So that turn, cough, beat, breathe becomes very significant. Okay? All right. That next slide is going to be a little challenge because I want you to go back now to the nursing care we used on page 137, 138. Yeah, 137, 138. I listed the nursing care specific to COPD. What I want you to do is I want you to number each of those bullet points, 1, 2, 3, etc. Not the hyphens, but the little dots, okay? And then I'm going to tell you how we're doing that whole comparison and contrast thing, all right? Okay, so I'm going to tell you how these things are the same or slightly different, all right? Okay, so you ready? So the first one there, head-to-toe assessment with focused respiratory assessment, that's the same. This is an acute problem representing a change in that person's level of function, and so they need a thorough assessment, especially a focused respiratory, to identify their nursing problems. So remember we talked about 3 nursing problems that patients can have respiratory-wise. We talked about compromised airway, impaired gas exchange, and ineffective breathing pattern. A client with pneumonia may actually present with all 3 of those, but we're not going to know it until we do that initial assessment. The second one, assess vital signs and pulse ox. Obviously, that's very important in this context as well, but expect to see their temperature, pulse, and respiratory rates being elevated. And sometimes, depending on how much distress they're under, their blood pressure as well. If the patient has moved from being pneumonia only to being pneumonia with sepsis, many times their blood pressure will be hypotensive at that point. The third one, provide oxygen as indicated. I mentioned a while ago that may not be necessary if there's no chronic respiratory disease that exists. All right, number 4, BiPAP or CPAP may be used. Again, that's primarily if the client already has COPD, otherwise it's rarely necessary. Okay. Allow position of comfort. Head of the bed up is usually, or Fowler's position is usually best. Again, if the patient wants that position, that's excellent. Allow for that in order that they would not be distressed by the difficulty they're having. Instruct in pursed lip breathing, again, may not be necessary if they don't have a chronic respiratory condition. Provide meds promptly, especially bronchodilators as prescribed. And so I mentioned an element of that is trying to make sure we give that first dose of antibiotic within the first hour of diagnosis. And then collect sputum and send for testing, monitor amount, color, and consistency. This is extremely important for these individuals because we want to be able to identify the best antibiotic to eliminate the disease process that's happening. And so we want to try to collect that sputum before that first dose of antibiotic if possible. Provide oral care every 2 to 4 hours. That's very important because if they do cough something up, it's nasty, it stinks, and it tastes bad. And so give them a way to rinse their mouth and refresh so they don't have to taste that for hours. Assess and treat nutritional deficits. Again, if somebody is basically healthy and succumbed because of stress, they may not have any significant nutritional deficits except what's happened in the last 2 to 3 days. But somebody who's chronically malnourished, they're not going to recover perhaps at all if we don't provide them a better nutritional state. So you may have to involve dietary in that process. Promote the clearing of secretions. Absolutely significant. So most of those same instructions are relevant and applicable for a pneumonia patient as well. And then lastly, I think I got something out of order here. Under that nutritional deficits, remember that we're going to treat it, but recognize somebody who has no COPD problem does not have the carbohydrate restriction that we talked about for somebody with COPD. Whatever tastes good and can meet their protein and calorie needs should be made available to them. Okay? All right. Any questions about any of that? Okay. Well, let's go ahead. We'll finish 1 or 2 more slides. I think we'll be almost to TD. Let's see if we can make it to the TD before we stop. All right? Okay, so another thing that's relevant for these clients is because they are potentially infectious, then we want to try to place them in a private room if at all possible, especially if they have a viral pneumonia that's much more easily spread. Cohort with similar diagnosis, so meaning that if you've got more than one patient with pneumonia, that's far better than putting them in the same room if you have to. That's far better than putting a pneumonia patient with a post-op patient, okay? Because we don't want the post-op patient to develop pneumonia. But regardless of who they were in with, keep them 3 to 6 feet apart. I think we're at top wall. Why is that significant? What's the relevance of that distance? Droplets, very good, excellent. So with that being said, we're going to move into infection control. Remember, we're going to use droplet precautions for these clients until they've been on some antibiotics for a few days. Okay, so if we have to take that client to radiology or somewhere for additional testing, then we might actually put a mask on the client rather than pass out gowns as we walk down the hallway and masks as they walk by somebody. And then teach them if they're going home to try to keep 3 to 6 feet away from other people until their cough has subsided or they've been on antibiotics for several days so that they minimize the risk of that pneumonia spreading through the community or through their coworkers. Okay, so we're up to teaching. Okay, because we've already covered the bronchoscopy. So what do we teach these people? Well, some of the same kinds of things we talked about before with a little bit of a twist. So first one, because theirs is potentially infectious, whereas a COPD is not, then we want to minimize that close contact. Help them to understand the risk that they close with other people. Recognize that this seems perhaps self-explanatory to us, but recognize the public doesn't always recognize how easy something can be spread just from their hands. What I mean by that is that they can spread that illness by something they touch almost as easily as when they cough or sneeze on someone. Okay, so help them to understand they need to dispose of that potentially infectious material so somebody else doesn't get it on their hands and then get it inside their mouth and respiratory tract. Proper hand hygiene is a part of that process. Help them to understand that even with a respiratory illness, hand hygiene goes a long way to keep the infection from spreading. And then vaccinations. What we talked about before is relevant as well. Teach them the value of having an influenza vaccination once a year. And for those who are high risk, getting that pneumococcal vaccination and then repeating it typically after about a 5-year window. It's suggested that they get a second dose. Now, I think your IGGI book talks about how there are slightly different vaccinations out there, and so they actually encourage, your current text is encouraging that a client who's high risk get both forms of the pneumococcal vaccine. So they get one at one point, and I think it's 18 months later, 12 to 18 months later, they repeat the other one. And so they have had both then as far as exposure. Okay? During that time of illness, we need to help them understand that their body is fighting a serious threat. And so they need to prioritize getting adequate rest during that type of recovery. But it also goes a long ways to protect those who are healthy. In other words, appropriate rest and exercise helps us maintain a healthy immune system. And that's true for nurses and nursing students, not just people in the community. So 6 to 8 hours at nightly is what the average adult has suggested needs. And then 30 to 60 minutes of aerobic exercise most days a week, and a balanced diet. Those 3 things and the adequate hydration we talked about earlier. So those 4 things can boost anyone's immune system to the point that even through exposure in the community, they might not succumb to pneumonia. And you as a nurse might not as well. And then make sure they understand the value and benefit of smoking, of not smoking, the only real benefit of smoking is if you've got investment in stocks in Raleigh or whoever those people are that produce those things. All right? So make sure that they understand that our government supports the tobacco hotline, and so there are free resources and free information and plenty of opportunities if they're ready to stop. One more slide and then we're going to stop for a break. Alternative therapies. So we're talking about those things that are outside of the typical approach. So I've listed 3 things that a person might consume that might help minimize their risk of developing pneumonia. Any questions real quick before we break? All right, so then let's come back at 1:35.